Hi there! So now, me and my partner Margot are gonna discuss to you these anti-tuberculosis drugs. So what are these types of drugs? These are medicines used to treat specifically tuberculosis, an infectious disease that can affect the lungs and other organs.
What exactly are these anti-tuberculosis drugs? So we have 5 generic names, which are isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin. And we have their brand names. So isoniazid is Isoneg, rifampicin as Nitricin Forte, pyrazinamide as Pyramin, ethambutol as Danbutol, and streptomycin as Streptorex. So now we have our chemical names. So isoniazid has a chemical name of pyridine 4-carbohydrazide, while rifampicin has a chemical name of 3,4-methyl-1 piperazonyl iminomethyl rifamycin, and pyrazinamide has a chemical name of 2-pyrazine carboxamide. Ethambutol has a chemical name of 2s-2,2,2s-1-hydroxybutane 2-il amino-ethylamino butane 1-ol. And lastly, streptomycin has a chemical name of D-streptamin O2-deoxy-2-methylamino Al-glucopyranosyl 1,2-O5-deoxy-3-C-formyl Al-lexofuranosyl 1,4-N-bis-amino-amino-methyl. Now we are in the drug classifications. So in terms of drug classifications, we are anti-tuberculosis agents in terms of therapeutic classifications, and in pharmacologic, isoniazid is an isonicotinic acid hydroxin. Rifampicin is a semisynthetic rifamycin B derivative. Pyrazinamide is a synthetic pyrazine analog of nicotinamide. Ethambutol is a semisynthetic anti-tuberculotic, and lastly, streptomycin is a aminoglycoside. Of pregnancy category, isoniazid along with rifampicin, pyrazinamide, and ethambutol are all in pregnancy category C, while on the other hand, streptomycin is in pregnancy category D. On the mechanism of action, so isoniazid, interfere with lipid and DNA synthesis, thus inhibit bacterial cell wall synthesis. My action consists of bacteriostatic or bactericidal, depending on organism susceptibility and drug concentration at infection site. Also is an active agent against Mycobacterium tuberculosis, M. bovis, and some strains of M. kansasi. So next we have me as rifampicin. So I impair RNA synthesis by inhibiting DNA-dependent RNA polymerase, and I may be bacteriostatic or bactericidal, depending on organism susceptibility and drug level at infection site. If you are resistant to me, you can develop M. tuberculosis rapidly. So I am usually given with other anti-tuberculosis drugs to prevent or delay resistance. Next, we have me as pyrazinamide. So I may be bacteriostatic or bactericidal in action, depending on the concentration of the drug attained at the site of the infection and the susceptibility of the infecting organism. My activity appears to partly depend on the conversion of the drug to pyrazinoic acid, which lowers the pH of the environment below that which is necessary for growth of Mycobacterium tuberculosis. Me as ethambutol, so I am an antimycobacterial and I am bacteriostatic against susceptible bacteria. I appear to inhibit synthesis of bacterial metabolites, thereby I inhibit cellular metabolism and multiplication. I interfere with mycolic acid incorporation into the myobacterial cell wall.
Lastly,
Me as streptomycin, my mechanism of action includes that I am bactericidal and I bind directly to the
30S
ribosomal subunit and I inhibit bacterial protein synthesis. My spectrum of activity includes many aerobic gram-negative organisms and some aerobic gram-positive organisms. Now we will go to our pharmacokinetics. So me, as isoniazid, I am absorbed readily from the GI tract and after IM injection.
my rate
An extent of absorption is reduced by food. Upon my time to peak plasma concentration is after 1 to 2 hours orally. I am distributed into all body tissues and fluids including CSF, and I cross the placenta and also I enter the breast milk. Metabolism, I undergo acetylation of isoniazid to acetyllisoniazid by N-acetyltransferase found in the liver and small intestine, which is then hydrolyzed to isonicotinic acid and monoacetylhydrazine. Isonicotinic acid is conjugated with glycine to isonicotinyl glycine, and monoacetylhydrazine is further acetylated to diacetylhydrazine.
upon excretion,
I am excreted via urine and feces, and my plasma half-life is approximately 1 to 6 hours.
Now, me as rifampicin, in terms of absorption, I am readily and well absorbed from the GI tract.
Reduced and delayed absorption with food. My time to peak plasma concentrations is 2 to 4 hours. In terms of distribution, I am widely distributed in most body tissues and fluids, including CSF. I cross the placenta and blood-brain barrier, and I also enter the breast milk. My plasma protein binding is approximately 80%. Upon metabolism, I am rapidly metabolized in the liver, mainly to active 25-O-deacetyl rifampicin, and I undergo enterohepatic recirculation. Lastly, my excretion is I am excreted via feces, urine, and my elimination half-life is 3 to 4 hours. Next is me as pyrazinamide. So, in terms of absorption, I am readily absorbed from the GI tract and my time to peak plasma concentration is approximately 2 hours. In distribution, I am widely distributed in the body fluids and tissues, and I diffuse in the CSF, and also I enter the breast milk. My plasma protein binding is 50%. Upon metabolism, I undergo hepatic metabolism via hydrolysis to pyrazinoic acid and subsequently hydroxylated to 5-hydroxypyrazinoic acid. Lastly, my excretion is I am excreted via urine by glomerular filtration, and my half-life is approximately 9 to 10 hours. Now we have me as ethambutol, and my pharmacokinetics includes absorption, which is that I am absorbed from the GI tract and my time to peak plasma concentration is within 4 hours. Upon distribution, I am distributed to most tissues, including kidneys, lungs, and erythrocytes. I cross the placenta and enter the breast milk, and my plasma protein binding is 20 to 30%. In my metabolism, I am partially metabolized in the liver into inactive aldehyde and dicarboxylic acid derivatives. And lastly, my excretion is that I am mainly excreted via urine, feces, and my elimination half-life is approximately 2.5 to 3.6 hours. Lastly, me as streptomycin, upon absorption, I am usually given by IM injection, and my rapid and peak serum concentrations are reached within 1 to 2 hours. In distribution, I am widely distributed after parenteral administration. Intraocular penetration is poor. My CSF penetration is low even in patients with inflamed meninges. So I cross the placental barrier and is 36% protein bound. Upon metabolism, I am not metabolized. And lastly, in excretion, I am excreted primarily in urine by glomerular filtration. Small amounts may be excreted in bile and breast milk, and my elimination half-life in adults is 2 to 3 hours, but in severe renal damage, my half-life may extend to 110 hours. And our indications include the treatment of M. tuberculosis
And me, streptomycin. My indications include plague, tularemia, and subacute bacterial endocarditis. Now on to Margot.
Now let's talk about my contraindications. I have general contraindications for patients with hypersensitivity to me. Now let's go to the specifics. For isoniazid, I'm contraindicated for patients with acute liver disease or a history of isoniazid-associated hepatic injury. And rifampicin, I am contraindicated for patients with jaundice or has concomitant use with squinavir, ritonavir combination, itazanavir, darunavir, usamprinavir, sakinavir, and diprinavir. Then pyrazinamide, I am contraindicated for patients with hyperuricemia and gouty arthritis, acute porphyria, and severe hepatic impairment. As ethambutol, I am contraindicated for patients with optic and retrobulbar neuritis and patients who have the inability to report visual disturbances, like patients that are unconscious. Now we're on the side and adverse effects. For isoniazid, here are its adverse effects. Emphasis on the seizures, toxic encephalopathy, agranulocytosis, aplastic anemia, and thrombocytopenia, hepatitis, and hypersensitivity reactions. Now for the rifampicin, here are its adverse effects. Emphasis in the pancreatitis, acute renal failure, thrombocytopenia, transient leukopenia, hepatotoxicity, and shock. Now for the pyrazinamide, here are its adverse effects. Emphasis on the thrombocytopenia, hepatitis, and hepatotoxicity. Now we're down to the two last drugs. So for the ethambutol, its significant adverse effects are optic neuritis and visual disturbances like color blindness and irreversible blindness. Now for the last drug, so here are its adverse effects. Now emphasis on the neuromuscular blockade, nephrotoxicity, leukopenia, thrombocytopenia, apnea, and angioedema and anaphylaxis. Now for the last part of our video, which is the nursing responsibilities before, during, and after. So the first drug is isoniazid. So for the before administration, the nurse must assess patient's infection before starting therapy by physical examination and culture and sensitivity testing. Next, the nurse must monitor patient for improvement and evaluate culture and sensitivity tests. The nurse must be alert for adverse reactions and drug interactions. The nurse must monitor hepatic function closely for changes. The nurse must monitor patient for paresthesia of hands and feet, which usually precedes peripheral neuropathy, especially in patients who are malnourished, alcoholic, diabetic, or slow acetylators. And lastly, the nurse must assess patients and families' knowledge of drug therapy. During the implementation, the nurse must give oral form of drug 1 hour before or 2 hours after meals to avoid decreased absorption. The nurse must switch from intramuscular to per oral form as soon as possible. The nurse must give pyridoxine to prevent peripheral neuropathy, especially in malnourished patients. Now, after the administration, the nurse must tell patient to take drug as prescribed and warn against stopping drug without prescriber's consent. The nurse must advise patient to take with food if GI irritation occurs. The nurse must instruct patient not to drink alcohol during therapy and instruct patient to avoid certain foods like fish, such as skipjack and tuna, and foods containing tyramine, such as aged cheese, beer, and chocolate. The nurse must tell patient to notify prescriber immediately if symptoms of liver impairment occur, like loss of appetite, fatigue, malaise, jaundice, and dark urine. Then lastly, the nurse must urge patient to comply with treatment, which may last for months or years. Next, drug rifampicin. Before administration, the nurse must assess patient's infection before starting therapy and regularly thereafter to monitor drug's effectiveness. The nurse must monitor liver function, hematopoiesis, and uric acid level. The nurse must be alert for adverse reactions and drug interactions, and nurse must watch closely for signs of hepatic impairment. If adverse GI reactions occurs, the nurse must monitor hydration. And lastly, the nurse assess patients and families' knowledge of drug therapy. During administration of the drug, the nurse must give drug 1 hour before or 2 hours after meals for optimal absorption. If GI irritation occurs, patient may take with meals. The nurse must keep in mind that drug may inhibit standard assays for folate and vitamin B12. Consider alternative assay method. The nurse must give at least 1 additional antituberculotics to reduce the resistance of the drugs. And after administration, the nurse must warn patient about drowsiness and red-orange discoloration of urine, feces, saliva, sweat, sputum, and tears. Soft contact lenses may be permanently stained. The nurse must advise patient not to drink alcohol while taking the drug, and then recommend taking drug with a full glass of water to maintain adequate hydration. Now on to the third drug, pyrazinamide. So before administration, the nurse must be alert for signs of hepatotoxicity, including anorexia, abdominal pain, severe nausea and vomiting, yellow skin or eyes, fever, sore throat, malaise, weakness, facial edema, lethargy, and unusual bleeding or bruising. Report these signs immediately to the physician. The nurse must assess any joint pain or arthritic symptoms to rule out musculoskeletal pathology. That is, try to determine if pain is drug-induced rather than caused by anatomic or biomechanical problems. Lastly, the nurse must monitor signs of blood excretions such as thrombocytopenia, like bruising, nosebleeds, and bleeding gums, or unusual weakness and fatigue that might be due to anemia. Again, report these signs to the physician. During administration, always wash hands thoroughly and disinfect equipment. This is to help the spread of infection, and use universal precautions or isolation procedures as indicated for specific patients. The nurse must keep in mind that this causes photosensitivity, so use care if administering UV treatments. After administration, the nurse must advise patient about photosensitivity and to use sunscreens, protective clothing, and avoid prolonged sun exposure. Advise patient to also report any rashes or other skin reactions. The nurse must instruct patient and family or caregivers to report other troublesome side effects such as severe or prolonged skin problems like rash, acne, or itching. And also GR problems like diarrhea, nausea, vomiting, and loss of appetite, or difficult or painful urination. Let's go to the fourth drug, ethambutol. So before administration, the nurse must obtain history of patient's infection before starting therapy, perform visual acuity and color discrimination tests before and during therapy. The nurse must monitor the drug's effectiveness by regularly assessing for improvement in patient's condition and evaluating culture and sensitivity test results. The nurse must monitor uric acid level and observe patient for symptoms of gout. The nurse must be alert for adverse reactions and drug interactions and assess patients' and family's knowledge of drug therapy. So during administration, the nurse must anticipate the need for a lower dose in a patient with impaired kidney function. The nurse must always give ethambutol with other antituberculotics to prevent the development of resistant organisms. After administration, the nurse must reassure patient that visual disturbances will disappear several weeks to months after the therapy ends. Also, the nurse must warn the patient not to perform hazardous activities if visual disturbances or adverse CNS reactions occur, and emphasize need for regular follow-up care. Last drug, streptomycin. Before administration, the nurse must monitor signs of hypersensitivity reactions, including pulmonary symptoms like tightness in the throat and chest, wheezing, cough, dyspnea, or skin reactions like rash, pruritus, or urticaria. The nurse must notify physician or nursing staff immediately if these reactions occur. The nurse must report any muscle weakness or paralysis that occurs following injection of high doses. The nurse must monitor signs of ototoxicity, including hearing loss, tinnitus, and balance problems. These signs must be reported, and the patient must be cautioned and family caregivers to guard against falls and trauma. The nurse must monitor signs of low magnesium levels, hypomagnesemia, such as lethargy, irritability, insomnia, muscle tremors, and confusion. Notify physician of these signs. During administration, like for all the drugs, always wash hands thoroughly and disinfect equipment. This is to help prevent the spread of infection, and universal precautions or isolation procedures will be used as indicated for specific patients. After administrations, the nurse must advise patient to report signs of nephrotoxicity, including blood or pus in urine, decreased urine output, fatigue, and weight gain from fluid retention. Now that's it for the anti-tuberculosis drugs. Thank you for watching.